to the recorded version of Addressing Social Isolation and Loneliness Among People Living with Dementia from June 25, 2019, part of the National Alzheimer's and Dementia Resource Center webinar series sponsored by the Administration for Community Living.
Thank you, Steve. Welcome everyone to the webinar today, Addressing Social Isolation and Loneliness Among People Living with Dementia. In this webinar series, the Administration for Community Living's National Alzheimer's and Dementia Resource Center has partnered with the American Society on Aging. We're pleased to have all of you in attendance today. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hi, everyone. I just wanted to thank you for coming to our webinar today. We appreciate you dedicating your time to this very important topic. And I'd like to thank Don Smith and Sarah Delaney for sharing their wisdom with us. And with that, I will give it back to you, Sarah, so we can get the show on the road. Thank you.
Great, thanks. As you heard, Don Smith and Sarah Delaney will be presenting today. Don Smith has served as Director of the Area Agency on Aging in Fort Worth, Texas for 14 years, and for Health and Human Service organizations throughout Texas for 34 years. Dementia and caregiving has been a focus and priority throughout his career. Sarah Delaney is a geriatric clinical nurse specialist at the University of California, San Francisco Memory and Aging Center. As nurse coordinator for the care ecosystem, she provides clinical consultation and supervision for care team navigators, as well as training and program implementation support. I will turn it over to Don Smith to begin the presentation. Don?
Thank you, Sari. In the early 80s, while I was working as a gerontology intern, I got fairly close to a dementia-related murder-suicide. Since then, finding better ways to serve this population has been one of the major missions in my life. Today, what I wanted to talk to you about is the Older Americans Act network, which I consider to be the foundation that we've been able to build on here in Tarrant County, what I refer to as the social isolation continuum, and some of the things we've been doing here in Texas. I'm very proud to be a part of the Older Americans Act network, and I've served, as you heard in my introduction, in several capacities within that network for almost 35 years. And what we've been doing here in Texas would not be possible if it had not been for the 50-year-old infrastructure of community-based organizations that have been built largely with funding through the Older Americans Act. We're one of 600 area agencies on aging in the United States, 28 AAAs in Texas, and we're one of only 2 area agencies on aging in the United States that are part of a United Way. Just as an aside, I wanted to mention that the Older Americans Act is up for reauthorization, and I think it's very important that we reauthorize the Act to enhance and expand funding for the Act, particularly Title 3B, C, D, and E. Did I say 3D? So it's just within the last 2 years that here in the United States that social isolation has become a public health issue. We're way behind some of the other countries, particularly the UK and Canada. The Canadians have been studying this issue closely for over 20 years. And one of the distinctions that they made very early on was the distinction between social isolation and loneliness. There have been 4 surveys here in the United States that have identified loneliness as the key issue and a high risk factor for heart disease, dementia, immune dysfunction, functional impairment, and early death, and now finally the National Academy of Science has kind of gotten in on the act and has convened a consensus study. What we're seeing here just anecdotally on the ground in Texas is what I refer to as the social isolation continuum, where folks are isolated, particularly those who live alone, then lonely, then chronic disease and depression sets in, and then finally, in some cases, we see dementia. People with dementia who live alone are also an increased risk for self-neglect, wandering, inability to respond to emergencies, financial exploitation. We've had several people living alone with dementia here in Tarrant County that have burned down their houses. One of the things we do not talk nearly enough about is the economic impact of dementia. I would like to thank our dementia-capable friends in Houston at Baker Ripley and Baylor College of Medicine for funding this data. It's from 2017. What you see here is that Medicaid is bearing the brunt of most of the expenditures. In fact, an individual with Alzheimer's or other dementias costs Medicaid, as you see from the chart, 23 times as much as an individual without Alzheimer's or dementia. That ratio is 20 to 1 for nursing home care and Medicare 3 to 1. Now, we don't look at the economic burden of people living alone with dementia as a subgroup, but what we do know based on the Alzheimer's Association 2019 Alzheimer's Disease Facts and Figures is this population has 29% more outpatient cost and 26% more hospital stays than those living with a caregiver. Those living alone with dementia account for 26% of the total population. And the one big shocker to me, which we found to be true over the past 3 years, is that 50% of those living alone with dementia do not have an identifiable caregiver. Just to set the context for the work we're doing here in Texas, I want to tell you a little bit about Tarrant County. We're the third largest county in Texas. Our two largest cities are Fort Worth. It says they're 15th largest in the U.S. Since we put this slide presentation together, I've learned that Fort Worth is the 13th largest city in the U.S. The other city is Arlington. You see AT&T Stadium, which is one of the more prominent landmarks in Tarrant County. One of the surprising things that we've learned from a recent United Way of Tarrant County community assessment is that 13.3% of Medicare beneficiaries here have been diagnosed with Alzheimer's. That's a good 4 percentage points above the national average. We've been working on this issue several years here in Tarrant County, dating all the way back to 2009. We were one of 2 sites for the community living program of Texas, and we focused on folks being discharged from hospitals that had been diagnosed with dementia. The other side here in Texas was the Central Texas Area Agency on Aging, who partnered with Baylor, Scott & White. I just wanted to shout out to the folks down at Baylor Scott & White Center for Applied Health Research. They've been with us on this long journey, particularly Alan Stevens and Jinmi Young Cho. Alan has served as the designer, trainer, and evaluator throughout the past 10 years. We've also had some assistance in evaluation for our United Way funded project, the Healthy Aging and Independent Living Initiative from Marcia Ori down at Texas A&M. One of the big learnings that we have had over this decade is that if we really want to make a difference in allowing people to continue living in their own homes with dignity and independence, we found that it's best to focus on those with low to moderate cognitive impairment. Over the past decade, we've been able to keep 90% of those who were a high risk for institutionalization in the community for over 6 months. And one of the big reasons for that is our featured evidence-based program for caregivers, Resources for Enhancing Alzheimer's Caregivers' Health, also known as REACH 2. So back in May of 2016, we were entertaining the idea of applying for an ACL Dementia Capable grant. And I noticed that one of the target populations for the grant was people living alone with dementia. We've been working a lot with caregivers of people with dementia, but honestly, I was a little naive about the extent of the problem. So I called up Carla Judson, who's the executive director of Meals on Wheels of Tarrant County, and I asked her, Carla, we don't have any people living alone with dementia in Tarrant County, do we? And she laughed. And they have a pretty sophisticated database, so she called me back 30 minutes later and she said, Don, the number is almost 600. In other words, we have 600 people who are receiving home-delivered meals that are living alone with dementia. So with that information, despite my being naive about this issue, we were funded. The title of that program is MOS, Model for Alzheimer's Dementia Services. We took a population health approach with the dementia capable funding, focused a lot of our work on unserved and underserved population. We wanted to focus a little more on people of color who had a higher prevalence of dementia. So a year later, you can tell that I've really drunk the people living alone with dementia Kool-Aid by now. I received a call from a newspaper reporter at the Fort Worth Star-Telegram who wanted me to comment on a community needs assessment that had just been completed by the large public health hospital system here, JPS. You can see this was on the front page of the Fort Worth Star-Telegram. I said, we've got people living alone with Alzheimer's and dementia right now. So about 2 weeks later, we were hosting a meeting of the Evidence-Based Leadership Council here in Fort Worth, and I got a call from the reporter who wrote the story, and he said, Don, you know, I can't stop thinking about what you said about all these people with dementia that are living alone. I'd like to do a feature story on that. So this is an excerpt from the feature story that was also in the Fort Worth Star-Telegram. So how do we find people that are living alone with dementia? Most of the referrals that we get are from home health agencies and hospitals. But we've also been able to tap into the home-delivered meal assessment process. Here in Texas, all home-delivered meal organizations that receive Title 3C2 funding through the Older Americans Act are required to complete a eligibility tool in order for a person to be eligible to receive a home-delivered meal. So we took a real close look at that and found that there are 3 questions that relate to cognitive ability. So an affirmative answer to any one of these 3 questions led to a more thorough cognitive assessment using the AD8. Did I mention the Older Americans Act and Title III are up for reauthorization? So what were we able to accomplish with MOS? We had 3 target populations, people with IDD at high risk to develop dementia, caregivers, dementia caregivers, as well as people living alone with dementia. We were able to get to 110 people living alone with dementia and provide them with dementia options counseling and connect them with other services, and also serve 342 caregivers. So the other thing we did, particularly since we wanted to do outreach to underserved, unserved populations and people with color, is we required all the partner agencies to complete culturally and linguistically appropriate services standards training. We think that had a lot to do with our partner organizations diversifying their staff and providing a lot more culturally appropriate services, so we were able to increase the percent of total population served in both the African American population as well as the Hispanic population. We were at the recommendation of Dr. Janice Knabel at the University of North Texas Health Science Center. We adopted the use of the AD8, the Washington University Dementia Screening Test. All partner agencies were trained by UNT Health Science Center and started using the AD8. And one of the things that happened over the course of the project is we evolved from a single point of access to a no wrong door, where our partner agencies actually completed some of the paperwork, including the AD8 up front. So a real shout out to our friends down in Houston at Baker Ripley, formerly known as Sheltering Arms, Jane Babineau and Katie Scott. We worked with them to put together this list of what we think are the pretty solid list of the most needed services for people living alone with dementia. Now, the one thing that may jump out at you from that list is the visiting physicians. I may get into trouble for saying this, but one of the most frustrating things for me about the MOS project has been the inflexibility and lack of adaptability of our healthcare system in serving this population. A lot of the folks living alone with dementia don't have access to transportation, particularly the poor folks who don't drive a car. And as we know, about half this population does not have a caregiver. One of the things that we've had heated debates about here in Tarrant County with our academic partners is the need for the health care system to adapt to better meet the needs of this population. In fact, I want to quote Dr. Janice Knabel, who's the Director of Geriatric Medicine here at University of North Texas Health Science Center. She says, "The future of healthcare is in the community." Clearly, our most important partner in serving people living alone with dementia was Meals on Wheels of Tarrant County. You can see they serve over 4,000 people a year. They've used that assessment that I mentioned to identify that 42% of the people they serve have dementia. 56% of that 1,746 are living alone with dementia, and only 31% have been formally diagnosed. So without Meals on Wheels of Tarrant County, it would have been impossible for us to reach this target population. And again, without the Older Americans Act funding that actually provided the funding for the meals, we wouldn't have had the infrastructure to reach out and serve this population. As I mentioned, while we had 3 target populations for our Dementia Capable grant, we did pretty well in serving the people living alone with dementia population, exceeded our goals, which is one of the reasons that we decided to apply for an extension. Our new project is called MOS, focused on people living alone. MOSPLA is the acronym. And we have some pretty ambitious goals for the project. One is to identify 1,500 people living alone with dementia and provide services to 950. Here's a flow chart that describes the process. We've added a couple new partners. We'll be trying to get visiting physicians or family medicine residents to go into the home and do cognitive assessments using the MOCA. Don't ask me what that stands for. And we're also partnering with the Financial Exploitation Prevention Center of Tarrant County to partner with the banks and get people in the home and get them set up for at-home banking with volunteers. So we've been working on a few other things here in Tarrant County. I mentioned our partnership with Baker Ripley. We're also partnering with the Texas Health and Human Services Commission to better educate the employees of dual eligible plans here in Texas to better serve people with dementia in their plans. We're part of a geriatric workforce education program grant. Our partners are University of North Texas Health Science Center, JPS, our large public hospital, as well as TCU. There have been a few great outgrowths of that grant. One is that we're receiving direct electronic hospital referrals from the public hospital system. People that are being discharged with dementia. Our public hospital system during this process became only the 2nd hospital in America to receive a delirium accreditation. We've been very fortunate in that we have both dementia-friendly Fort Worth and age-friendly Fort Worth here. One of the challenges has been to integrate those two, but we've done a pretty good job, we think, of integrating dementia-friendly, age-friendly, and expanding that throughout Tarrant County. We'll be training a lot of the businesses and designating them as age-friendly or dementia-friendly as a part of this, our new MOSPLA project. We just published our 3rd edition of a health resource guide for caregivers and just received a $1.15 million grant from the Texas Health Resources Hospital System to serve socially isolated populations and high-need zip codes, and also to address food insecurity. So we'll be working on the front end of that social isolation continuum that I referred to. So this is probably the most important slide. It says that AOA and ACL doesn't endorse my opinions. That's probably an understatement. And finally, I just wanted to say my father, Benny D. Smith, died on June 12th. He was a retired telephone company engineer who worked on projects all over Texas. In his final days, the minister asked him if he had any regrets. He told him, and this was part of the memorial service, he said, "I wish I'd been able to help more people." In honor of my dad, I would like to challenge all of us to help more people, particularly the most vulnerable who live among us. And with that, I will hand it off to Sarah in San Francisco.
Thank you, Don. It's great to hear about the work you've been doing with your team in Texas. And my name is Sarah Delaney. I'm a clinical nurse specialist at the UCSF Memory and Aging Center, and I'm going to talk about addressing dementia in the context of poverty and social isolation. And the work we've been doing with the care ecosystem has been supported by the UCSF Medical Centers, Centers for Medicare and Medicaid Services, the National Institute on Aging, and the Administration for Community Living. And the objectives are more to keep myself organized, so I'll go ahead and move beyond those. So to give you a sense of the care ecosystem model, this was started around 2014 with funding from the Medicare Healthcare Innovation Award. Our team at UCSF wanted to expand access to dementia expertise for people no matter where they live. We see over 5,000 patients a year here at the Memory and Aging Center, and there's a long wait list, and just recognizing that there's a growing population and we need to do something to expand access. So the key role or player in this model is the care team navigator, who's modeled after the navigator role that's been used for cancer programs, cancer care programs. And the navigator is an unlicensed role. They kind of act as a care guide, working primarily over the phone with caregivers. They're trained. They receive about 80 hours of training that includes lecture-based training as well as shadowing in clinics and visiting community-based services. And they're supervised and supported by a multidisciplinary team that includes a nurse, a social worker, sometimes a pharmacist, and sometimes the pharmacist role is covered by a physician depending on the setting. So the care team navigator works most closely is a primary point of contact with the caregiver and the patient. In our randomized controlled trial that was initially funded by a Healthcare Innovation Award and is continued with funding from the NIA, the navigator primarily has worked with caregivers. It's a telephone-based program, and patients are typically not able to, engage on the phone for long periods of time. And so the navigator provides support and education and links these dyads to community services and coordinates care with healthcare providers. So they act as a supplement to existing healthcare services, and the clinical team both supervises and then provides consultation for complicated behavioral challenges, safety issues, or benefits questions that are beyond the scope of their practice. So they receive a lot of training, and then in addition are guided by care protocols around issues like medications, behavior, safety, caregiver well-being, and advanced care planning to guide the work they do. And this also helps as part of our sustainability model, which I'll describe later. So you can see in pink are two implementation hubs for our care ecosystem trial, which is at UCSF and UNMC in Nebraska. So that's where people are randomized into receiving the care ecosystem or receiving usual care, and they have telephone follow-up. We also have implementation sites in Minnesota, Denver, and New Orleans, as well as our local implementation sites at Curry Senior Center, which is the main area that I'll focus on today, and our Memory and Aging Center. So our goal is to have this type of care and support become a standard of care for all people with dementia. And these implementation grants have allowed us to test this model as a part of usual care. So Curry Senior Center is a really unique neighborhood-based primary care and case management center. So that's, they have a foundation as well as a clinic that's funded by the Department of Public Health. They serve older adults who are 55 and older in the Tenderloin neighborhood, which I'll describe. But they're really a low threshold service provider, meaning, you know, there aren't a lot of enrollment steps. People can just kind of drop in and get connected with services. And I think that's been really important in their success in serving older adults who live alone with cognitive impairment. So I wanted to give a sense for those of you who haven't been to San Francisco or the Tenderloin neighborhood of what it's like. It's there's a lot of homelessness. At one point it was a tourist center in the past, and so there are these old hotels that have been converted into single-room occupancy hotels. So very small sort of dormitory style apartments, and this is the kind of living situation that most of the patients at Curry live in. The buildings are managed by different kinds of organizations, so some buildings you know, may have additional services, and others are pretty bare bones, and there can be you know, hygiene and safety hazards. So there is a lot of homelessness on the streets, as well as drugs, trash, and crime. Some have described it as sort of a containment zone for violence and drug use in San Francisco, which is otherwise a prosperous city right now. So the map on the right shows just a week in crime incidents reported to the police in May. You can see it's concentrated around the area where the Tenderloin neighborhood is. And the map on the left is data from 2017 from the CDC for drug overdoses in the city. So the older adults who live in the Tenderloin, there's about 12% of the population is over 65, and they're predominantly Asian Pacific Islander. The Tenderloin is near the Chinatown in San Francisco, which is another neighborhood that has a lot of SRO hotels. There are also a significant number of African American and Hispanic residents. The majority of older adults living in the Tenderloin are very poor. Half of them have limited English skills, and almost 50% of them live alone, and 12% identify as LGBTQ. So in spite of the challenges of life in the Tenderloin, when you walk around the Tenderloin, it does have a strong sense of community. When we were initially starting this project, I walked around with a case manager, and he would run into some of his clients on the street and knew local police officers and people at coffee shops. So there is a strong sense of community, a lot of activism of people who live there who are trying to improve neighborhood conditions, and actually a lot of social services serving residents in the community. So we really, took this model that was developed, the care ecosystem, working with people who have caregivers and phones, to translating it to working with people living alone, very socially isolated, limited resources, and trying to help them, stay safe and engaged in life in the Tenderloin as they're losing their own self-management skills. So one of the things when we were initially working with the team at Curry, since they do have case management services, they have a pretty small clinic. So they have 3 providers and they see close to 1,500 patients a year. Their case managers serve about 500 patients a year. So there's a lot of people who aren't getting case management services, and we saw value in having the navigator sort of be a bridge between the primary care and case management. So people who are doing kind of okay, it seems like, on their own, but need, more supports in place but don't yet qualify for case management. So things that the Curry Clinic were already doing to enhance access to care is that they accommodate drop-in appointments. So obviously not everybody that has cognitive impairment is going to be able to remember or keep appointments, and so they are set up to provide drop-in visits. The providers also do home visits. Nurses sometimes do home visits. So that was already in place. However, their patients, if they needed a referral to a dermatologist for suspected skin cancer, or they needed dental care or help getting a hearing aid, it's these kinds of healthcare services that the patients didn't have access to because there was no family caregiver to take them to these visits. And so this has been something that the navigator has really been instrumental in helping increase access. They'll even escort the patients and go with the patients to their appointments, and when they're not able to arrange for in-home care providers to provide escort services. They also, in many ways are sort of doing the types of things that a family caregiver would normally do. So medication management is a common problem for people with early and moderate cognitive impairment, including, managing prescription refills. So the navigator can help set up the system. They're not necessarily implementing the system themselves, but working with in-home supportive services. And the pharmacist sometimes at Curry, or the pharmacy around getting medications delivered to help set up a system that's more sustainable. And most of the participants receive meal delivery, as Don mentioned, is really critical for his population as well. And then, really trying to be creative and problem solving. So if the person wakes up and they don't want to go to the dentist that day, trying to figure out, how to get them to go or how to rearrange the visit to be more successful. And also, if the person, Don mentioned, having a fire, there was one participant who had their activity was to set up a shrine and light candles in their home, which is a clear safety risk, and the navigator was able to work with them and a volunteer around learning how to knit and have a different activity and set up the shrine without candles. So sort of thinking outside of the box. And, these are patients who, don't come to you with a problem list of, these are my goals and this is what I want to work on, this is what I want you to help with. They're also not people who are going to complain typically about not getting services. So we really have to, be good observers and identify ways that we can be helpful. Common safety hazards the navigator will address. So I should mention, while the providers at Curry do home visits, they don't do these visits, frequently. They don't have the bandwidth to do that. So our navigator, because most of the patients who are seen at Curry live within a 5-block radius of the clinic, the navigator can walk to do home visits. And so home modifications, such as for falls, the navigator may even walk to deliver, a bedside commode, or help refer to county-based injury prevention program to get, shower modifications. They work to get medical ID bracelets for anybody who doesn't have them. one resident wasn't able to open her windows, and actually was a smoker, so that was a real air quality hazard. They can, screen the home for spoiled food, address, work with the building manager and the Department of Public Health around any building infestations, assess whether the patient would be able to use a phone, and if not, if they could use an emergency alert device if they were to have a fall. And then, importantly, be another set of eyes on what's going on in the living situation to monitor and document any incidents as needed. And often in these situations, as the dementia progresses, we're trying to evaluate, is a person safe to stay at home? Is their quality of life better in this SRO than if they were to be placed? And San Francisco has a critical shortage of long-term care beds, so that's a real resource issue. And also, as I said, there is a sense of community in the Tenderloin, so we want people to be able to live with as much dignity and independence as possible. As Don mentioned, these people living alone with cognitive impairment are at increased risk for exploitation. So screening for any signs that, if they have friends who might be taking advantage of them, or they're falling prey to scams. One participant lost his keys and was just kind of waiting outside the building until his neighbor showed up. There wasn't a building manager, and it took many, many calls and tracking down the landlord to get an extra copy of keys, and now that they have an extra copy of keys at the clinic. So also living in these SROs, if they forget to lock their door, or their clothes and bedding being stolen, helping them keep track of the belongings that they do have. And while the navigator doesn't get involved in managing the person's finances, they do want to have a sense of how the bills are paid, and be alert for any problems with paying bills that might contribute to eviction. So again, just providing that ongoing monitoring to see when the person's needs change. The navigator has a key role in advocating for increased in-home supportive services hours, and because home care workers paid for through state Medicaid funds, there can be a high turnover, so the navigator can help reinforce what the care plan is to make sure that the patient is getting the care that they need. So a key activity as well is identifying any social contacts. These are people who, as their disease progresses, will lose the ability to share their story or talk about their preferences and values. And so as much as we can document what we know, what we learn, the navigator spends a lot of time when the person is able to learn about what's important to them, what they did in their previous life. For example, someone who was an accountant managed all his appointments by keeping little slips of paper in a paper bag, and was really resistant to trying a different way of managing his appointments, but it makes sense in the context that he was an accountant and probably had to deal with lots of receipts and stuff in his professional life. And then just so observing how they're managing their daily life, as that might inform care. These people are more likely to be placed earlier. Little Brothers Friends of the Elderly is a volunteer visiting program that the navigator works with to try to increase social contacts. And Miracle Messages is a nonprofit organization that can help find family members who might be estranged. Prepare for Your Care has low literacy advanced healthcare directives and videos, so the navigator, even if the person doesn't have a friend or family member they can identify as someone they would want to make decisions on their behalf, they can talk to them about the kinds of care that they would prefer and maybe what their previous experiences were with people who are close to them to get a more nuanced understanding. The outcome measures that we're looking at are a number of medications. We find that people who live alone with dementia actually have fewer medications than people who have a primary caregiver. This is probably because there isn't someone who's able to manage the medications for them. The navigator is also assessing depression using the GDS and loneliness with the UCLA 3-item scale. And life space is a measure of how far the person leaves from the place where they sleep in a week. And the majority of people living in the Tenderloin have a life space of about 4, so they don't tend to leave the Tenderloin neighborhood. However, if people are living with a life space of 4 with early moderate dementia, that's a larger life space than they would have potentially in a nursing home or care facility. We've developed a care planning tool to help, again, because this population is not going to give you a to-do list or a list of goals. So to help make sure that we're being comprehensive in our assessment and think critically around opportunities for helping these people improve their quality of life and stay at home. This tool is adapted from Southern Maine AAA's Dementia Crisis to Thriving Scale, which we actually found on the NARDC website. So to date, our navigator has served 71 people. Majority are living alone without a caregiver. There's about a dozen that have a family caregiver, and this category of other caregiver is usually a paid caregiver who's been with the person for a while, but may not be doing as much as a family caregiver typically would. We have a pretty diverse cohort with mostly white, but also some Asian participants. And our overall sustainability plan is the Curry Senior Center is a federally qualified health center. So our plan is to use these annual wellness visits and complex chronic care management codes. So annual wellness visits are more comprehensive assessment visits that have a higher reimbursement than the typical E&M visit codes that providers bill for at Curry. And complex chronic care management covers or pays a monthly reimbursement for non-face-to-face work that can be provided by the navigator but billed by the provider. So we're still working towards this with the Department of Public Health and working in the interim with the Curry Foundation to get funding to continue the navigator role beyond our funding award. So I need to wrap up soon. So just in summary, to increase access to care and services, it's important to provide drop-in visits, home visits, and escorts and transportation for follow-up care. And in any way possible, reduce the burden of eligibility and enrollment processes, particularly for things like day programs. There's a lot of paperwork. So any way that we can use electronic medical records or direct referrals to reduce the burden of enrollment processes, I think would improve access to care. And then engaging in advanced care planning discussions, even if someone doesn't have an agent, they're able to identify that it's important to document these conversations and document as much as we understand about the person's values and preferences so that they can have care that's aligned with their values and preferences. For anyone interested in more information, we've developed an implementation toolkit, and we're currently developing training videos that will be on demand, less than 10 minutes each, and with little quizzes to test knowledge so that other settings can implement the care ecosystem model and not have to invest in in-person training. So with that, I want to pass it back to Sari so we can get to questions. Thanks so much.
Thank you so much, Sarah and Don, for your excellent presentations. We have quite a few questions that came in, so I want to get started with those. If you have questions you'd like to ask, please put those into the question and answer chat pod, and we will get to as many as possible. So for both of you, Sarah and Don, if you could respond to this question. Someone asked you, if you don't have funding to implement a program or intervention that focuses on addressing the needs of people with dementia who are socially isolated. What are the biggest takeaways that you can offer to people of maybe the top few things you can try to address? Sarah, do you want to start?
I guess I can start. I think the most important thing is to be able to identify this population. And due to the Older Americans Act network, there's an area agency on aging everywhere. And almost every area agency on aging has received revenue through the Title 3C2 of the Older Americans Act to deliver home-delivered meals. And almost every state requires some kind of a functional eligibility tool in order to determine eligibility to receive that home-delivered meal. So most of those tools include a few questions on cognitive ability. So that's if you can partner with your home health organization and use those tools as a starting point to determine who these people are and where they live, it's much easier at that point to find additional revenue to serve that population. And there are other pots of revenue within the Older Americans Act, particularly Title 3B for supported services, 3D evidence-based services, and Title 3E for caregiver services that can be tapped into to address this population and get programs started.
I think I'm going to agree with Dawn. I think, I would maybe have a different answer for the particular population that we're working with, but I also want to recognize that, these are sort of a concentrated community of older adults who live in an area that has a lot of supportive services that are already identified because they're dropping into the Career Senior Center. So I think identifying them is really the most important. And once they're identified, finding the lowest threshold way to provide care, which in this case, if it's in the neighborhood and they can drop in, great. Otherwise, I think home visits, if people are not going to be seeking care on their own, perhaps programs like PACE. Medications and access to follow-up care have been really significant in terms of healthcare access, and as well as advanced care planning. So I would say those are the three priority areas once someone's engaged in services and healthcare.
Yeah, and if you look at the slide on essential services that we put together with our Houston partners, I think that's got a pretty comprehensive list of the sorts of services that are most needed by this population.
Great, thank you. Sarah, can you talk a little bit about the caseload for the Care Team Navigator with the care ecosystem?
That's a pretty broad question. I can say that while they've served 71 people, they have an active caseload of around 60, and maybe a dozen that they're doing very frequent follow-ups, like almost weekly follow-ups with. So I would say they're in the early to possibly moderate stages of dementia, which is kind of surprising that people can manage to live alone with moderate stage dementia. I think, that we've worked with an organization called Homebridge, which manages in-home supportive services, and that's a very helpful resource to have, because again, that's something that a family caregiver would normally do in terms of hiring and managing home care providers. And San Francisco, because of the shortage in long-term care beds, are really, focusing on trying to keep people safe at home for as long as possible. So we're lucky in that there are a lot of services available to try to support that.
Great, thank you. Dawn, can you talk a little bit about some of the strategies you use to get hospitals and rehab centers on board to provide supports for people that are socially isolated with dementia upon discharge?
We've been working with 5 different hospital systems here in the Dallas-Fort Worth area for almost a decade. They've partnered with us to host and provide staffing and resources for matter balance, fall prevention classes, also Stanford chronic disease self-management classes. So we've been able to leverage those relationships to, I guess, build a bridge between community-based services and hospitals and clinics. I will say that being part of the geriatric workforce education program here and having academic partners, TCU, University of North Texas Health Science Center, as well as the large public hospital system, JPS here, certainly opened a lot of doors for us that made it possible for us to receive referrals directly from those hospital systems.
Great, thank you. I think we have time for just one more question here. Someone was asking if you could please describe in a little more detail the difference in the 2 columns on the slide that I just put up, the individuals without Alzheimer's or other dementia and the individuals with Alzheimer's or other dementia. Is the difference
a little more detail?
Yeah, can you provide a little more detail?
Yeah, actually that, I know I credited Baker Ripley for that, but the actual source, which I think will be in the corrective slides that will be sent out, is the 2017 Alzheimer's Association Facts and Figures. But I know the 19 figures that we looked at did not include the Medicare and Medicaid numbers, but I think it's pretty striking, and I know when we discuss the disparity between people that do not have Alzheimer's and those who have Alzheimer's or dementia and the cost to healthcare plans, it definitely gets their attention, particularly that ratio of Medicaid spending. The average person with Alzheimer's or dementia is costing Medicaid $8,399, and a one without cost Medicaid $358. That's a 23-to-1 ratio disparity, and again, when we talk to healthcare payers, that definitely gets their attention and has opened the door for a lot of conversations about the value of community-based services and helping keep people with low and moderate stage cognitive impairment living at home for as long as possible and out of nursing homes, which also that's actually a 21-to-1 ratio in cost between the person with Alzheimer's and dementia and the one who doesn't have Alzheimer's and dementia. I don't know if that answers your question. I think it's interesting that the typical person with Alzheimer's or dementia costs Medicare 3 times as much as the person without dementia and Alzheimer's, and I think that's only because Medicare doesn't want to open the door to providing more services to this population.
Great.
I don't know if that answers the question or not. Yeah.
I think we're good. We actually are out of time, so I want to thank you both again for your presentations and turn the floor over to Steve Moore for just some outgoing announcements.
Great. Thank you for your presentation today, everyone. Thank you for joining us.